Sir, my concern is everybody is coming in our clinic with many allopathy medicines and all other medicines. Then how we can help them with our Ayurvedic medicines?
Dr. Shilpa, people will be coming to clinics with a lot of medicines, as you said, it's right. Like for medicine for hypertension, medicine for diabetes mellitus, medicine for cholesterol, medicine as a prophylaxis management for coronary artery disease. After angioplasty and bypass, they will be on medication for nephropathy, calculus, and a big long list of medicines they will be taking. No? These all are the mandatory schedule as per allopathy norms, and public is also thinking that it will be lifelong, okay, including insulin. So what we are doing that scientifically we are tapering, okay, safely we are tapering. Based on lab findings, based on symptoms, based on observations on vitals, we are slowly tapering these allopathy medicines. Okay, at a point if we are not getting safety, we will stop this management. Understand? So now we need to taper the medicines. For example, I already told you diabetes medicines we have made in 3 zones, red zone, blue zone, yellow zones. Similarly, every diseases I had categorized all medicines in allopathy under these 3 zones. Scheduled medicines or medicines that are using for vitals, medicines that are using for emergency are coming under red zone. Like diltiazem, digoxin, etc., using for hypokinetic myocardium are coming under red zone. Against secreptins, including insulin, like vildagliptin, saxagliptin, rosigliptin, okay, these sitagliptin, again voglibos, that kind of medicines and diabetes. Again for allopathy like amlodipine, telmisartan, beta blockers like atenolol, AC inhibitors, calcium channel blockers, furosemide like alpha blockers. These all medicines, when we taper, we can add safe Ayurvedic herbal medicines along with. Okay, and telling to monitor these parameters at their home itself, BP and sugar, etc. Or we will have firstly 5 to 10 days periodical observations as for clinical follow-up. We can also assess the safety by direct inspection and observations. Based on that, we are directly going ahead by tapering the system. And if it is a combination, we will split. For example, rosuvastatin with aspirin, usually not good with Ayurvedic medicines. So we make it statin as a meritorious practice to be taken at night after food, and aspirin as antiplatelets at noon after lunch. This kind of splitting, this kind of different combinations have been tried with herbal formulations. Okay, not even herbal mineral, purely herbal medicines that are found to be 100% safe and potent. That is how we can, once after establishing the power of nature for maintaining the vitals and also maintaining the biochemical status, including sugar, etc., cholesterol, etc., uric acid, etc. Definitely, ekdam we can stop the medicine also, Ayurvedic medicine also. That's what, that's the advantage you see. Whatever the achievement, whatever the result positively we availed by giving Ayurvedic medicines will be retained even after stopping the medication. That's a major advantage. That is not possible with other system of medicines, I feel. And that's why people have to take it lifelong. So this practice is very meritorious and important nowadays. That's why this question is very relevant. Okay. Most important thing, we have to be very careful while dealing critical managements. So you need to have frequent sitting in the orientation programs, CME programs. Understand? So you have to be specialized in it. For example, if it is a coronary artery disease, what are the ECG variations, echo and lab test, enzyme markers, A to Z. You must know to safeguard the patient. Everything you need a reorientation. It's a big program of training, but it is possible. I have made it possible by nearly 2 decades of hard work. Okay, and now I'm 100% happy, and I have courtesy with my patients who are cooperated for this management. It was not a trial, because as I was scientifically monitoring, I had never got a single fatal incident. So I never felt any risky incidences. That's why I am very excited to share these informations to my class of doctors called Ayurvedic doctors, and all are welcome. Okay, I'm cordial welcome all of my Ayurvedic doctors to meet this challenge. Okay. Thank you for asking this question, doctor.
Sir, one
Very
more
good.
question is there. Like in modern practice, some people are getting some lymph node or fibroids, anything. Some people are coming. They are just firstly they send them to biopsy. So, but when these type of patients comes in your clinic, then you are telling them to not to go for biopsy.
Yeah.
So it's any relevant anything about this?
Dr. G, see, biopsy of fine needle aspiration cytology (FNAC) are the mandatory schedule for surgical diagnosis.
Yes.
Okay, so for a clinical diagnosis that is not mandatory. So just with MRI scanning or CT scanning or with ultrasound scanning, we can get a macroscopic picture, and by assessing the pattern, we can guess what could be the type of growth. Okay, so just give a safe medicines from Ayurvedic formulations for 1 or 2 months. Nothing is going to happen in 1 or 2 months.
Yes, sir.
Okay, only some exemptions we get in brain tumors as it cause pressure changes leading to epilepsy, etc., and acute headache, getting man unconscious, coma, etc., as a transient attack of coma. This context, of course, we are not supposed to take risk.
Yes, sir.
Otherwise, just for this kind of growths, before doing biopsy, better you just manage the patient for assessing the response.
Yes, sir.
Once if the biopsy is done, okay, it has to we need to take the step in the subsequent strategy in the surgical diagnosis. Surgical diagnosis, what does it mean? See, meaning is diagnosis before doing surgery.
Yes, sir.
Okay, medical management before doing oral consumption of medicines, we do just other techniques other than FNAC. So always, if you prick the red pulp organs like kidney, liver and spleen, or if you prick an encapsulated gland with a cyst, or especially a cortical cyst, it can show, okay, some bigger grades of infiltration of metastasis towards the secondary lymphatics or to the capillaries. Okay, so that may cause some undesirable impacts if it is malignant. So that is why always see, if it is malignant, definitely immediate surgery is mandatory. So we also are not supposed to. That's what in 1 or 2 months nothing is going to happen. That's why especially breast cancer and lung cancer,
Yes, sir.
renal cell carcinoma, hepatoma, hepatocellular carcinoma. All this is better before doing endoscopic biopsy. Just have 1 or 2 months of trial, assessing the enzyme markers, assessing the size, assessing the pattern of lymph nodes and para-aortic, vena cava lymph nodes, assessing the response of the medicine 1 or 2 months. We can definitely send them for the surgery.
Yes, sir.
After biopsy.
Okay.
I feel that's a safe step that we can follow. Okay.
Okay, sir.
That's why I am not against a biopsy, but biopsy is mandatory only for surgical diagnosis.
Okay, sir.
Understand? That is why I am not recommending that people before starting my treatment.